start with our first speaker, none other than the president of All India Ophthalmological Society, Dr. Mahipal Sachdev. To introduce him, I just handed over to Dr. Sonu Goyal.
Thank you, Krishna. I think the topic, the mystery cases, is all what we'll be dealing in the next 2 hours. And it is none other than our own president who will be speaking on the mysterious smile. So let's see what mysterious smile sir has to give to all of us. And it's a pleasure to welcome Professor Mahipal. Is my slide visible, Krishna?
Yeah.
So, Dr. Mahipal Sachdev is the president of All India Ophthalmological Society. He is the chairman, scientific committee of the IRSI. He is the chairman and medical director of Center for Sight, and he was honored with the Padma Shri Award, which is India's the highest civilian award, in 2007. He is a renowned ophthalmic surgeon, recognized for his expertise in the area of corneal, refractive, and cataract surgery, both nationally and internationally. He is widely credited to be a pioneer in India in propagating the technique of phacoemulsification for cataract, smile, and all arena of refractive surgery across. So I think he is among the top surgeons worldwide, the most wanted. So all to you, President Sir. Thankful for making for us.
Thank you very much, Sonu, and thank you again. I'll be talking about the tips and tricks of smile. So essentially, it's going to be a talk on how to get your outcomes good and where all you can go wrong and how do you get the right results. Is everything there?
Yes, sir.
Yeah, okay. So when we are looking at outcomes in refractive surgery, as I was talking in the introduction, that we have moved from conventional LASIK, which was where we were using a microkeratome blade to create a flap and using an excimer laser to reshape the cornea. And then in 2006 or 7 in India, there was the introduction of blade-free LASIK, that is the femto LASIK. And that time it was the FS60 that was there. And over time, there have been improvement in the femto procedure also. But the biggest revolution, I would say, that has come is the use of a single step procedure that is called a smile, where we have reduced the flap, which is a 22 millimeter flap that is being created, to an incision which is only 2 millimeters. And it has become a single step procedure, wherein instead of photoablating or burning corneal tissue, we are instead creating a lenticule with a femtosecond laser to carve out the cornea in the methodology that is there. As of now, clinically, we still don't have hyperopic corrections that are available, but it is going to be possibly available pretty soon, maybe within a year's time that is there. Now, when you are looking at the smile procedure, there are 4 steps to the smile procedure. The first step is essentially you have the bottom of the lenticule, and then depending upon the thickness, this is an aspheric profile. You create a side cut, and then you have a cap, and then you make the 2 millimeter or 3 millimeter side cut that is there, which is called as the cap opening incision. So there is a contact interface, which is a gentle contact interface, which is 360 degree, and it is not a hard dog that is there. So there is minimal applanation, and the curvature or the surface of the cornea is very well maintained with minimal intraocular pressure. There is no vision loss during suction. It is only when the OBL layer comes into the center that there could be a loss of a person seeing the green blinking light that is there. Now, the corneal fixation assures a better fixation than the scleral fixation only, and gives you a precise treatment positioning with low suction pressure, minimal applanation, and minimal IOP increase that is there. And this you can see is the cross section of the contact surface that is there with small holes, which gives you a 360 degree suction that is there. Now, the duration of treatment, what is very, very important is that you have to set the laser parameters as per the machine. And that is something very important, that each machine behaves a little different, and the amount of energy setting should be reduced to the optimal level, where you don't have like a Christmas tree OBL or you have cold spots. So therefore, the setting has to be great, and that needs to be individually done for each particular machine that you are using. Now, the treatment is independent of the power corrected. That is something very, very important. It is only the thickness of the lenticule that is going to be different. And it is not that if you are treating a -1 or you are treating a -10, as in the case of excimer, the time that is taken would be in the 20 seconds, 23, 24, 25 seconds, depending upon the optic zone that you are creating for that particular patient. The workflow is superior, and there is no influence of the environmental factors and stromal bed hydration or humidity of the operating room. So this is a standard procedure that is done, wherein you can see that this is the green blinking light that is there. You can see that the pattern is reasonably good in this particular case. And this is the posterior surface of the posterior lenticule. This is a 360-degree side cut that is happening. And this is now the cap cut which is there. And there is the side incision that comes through which you are going to take away the lenticule. Now, once the suction, automatically the machine, there is audio command and the machine automatically leaves the suction. So what you have to do is you bring the patient into the microscope. That again is a great feature. Where once you have the person coming down from the patient interface towards you, the microscope light automatically switches on. And these are the two planes that you have to dissect. This is very, very important. For everybody, the best way is to go on the anterior plane. As you can see, this is on top of the lenticule, and therefore, if you go to the bottom of the lenticule, the lenticule would stick to the upper part, that is the cap, and it becomes a little more difficult. And I'll talk about the dissection difficulties that you can have. So once you have separated it out, you can see at the time you have gone above the lenticule, you will not be lifting up the edge. Just watch here very carefully. You can see that there is an edge lift. Can you see that there is an edge lift? This shows that you are posterior to the lenticule, and that is the second step that you have to do. Go back in the posterior to the lenticule, and you do not separate from both the sides totally, because otherwise it tends to just roll over. So this is the forceps that you are using to take out the lenticule. So this is, you can see the exquisite surgery. It's the most gentle surgery, and this is how the lenticule comes out. And if you want to see, you can put it on there and kind of spread it to see whether the lenticule is complete or not. There is the problem of retreatment. As of now, commercially, we don't have the possibility of a smile being retreated as a smile, but you can do what is called as a circle scan, wherein you can see that the cap which is there is made into a flap. So this is a new cut that is initiated, and I'll just show you for retreatment. But one thing suffices, all the people who are here who are doing smiles, you can see this. This is being coming out. This is the same thickness at which you had the previous cap, and you are working here, and then you have created a side cut. There is a donut kind of circle scan that you have got, and this is the place from where the previous lenticule was removed, and now you are doing an ablation and bringing it back. The flap is being put back, and this is like a fresh cut. So the chances of epithelial ingrowth are much less, or it is as much as a new flap that is there. One thing which all of us who have switched over to smile have noted, that the incidence of retreatment is much lower than you had with the excimer. So there is no risk of epithelial ingrowth, and smile then LASIK is actually safer than LASIK after LASIK because epithelial ingrowth does not happen. Now, there are certain possible challenges with smile, which I will be discussing as regards the mystery, and these are the challenges that have been written. The intraoperative and the postoperative, I'll be dealing mostly with the intraoperative challenges. Just to tell you that whenever you are using a femto, if you have an interface debris, which you can see here, this is the cilia of a patient who's having an interface debris, there will be a cold spot. If there are minor threads, etc., fibers, I mean, then there is no problem. But in case you have a cilia, it is prudent that the laser should not be fired and the cilia has to be removed, because you will get a cold spot, and it becomes a little difficult, as you can see here, to separate it out. So this is one of the things that one has to be very careful. Now, the second thing I will be talking about is suction loss. Suction loss basically is a problem because the duration of the laser is slightly more than what you have in a flap. If a flap can take 12, 13, 14 seconds, this is going to take about 23 to 25 seconds. And also the suction is more gentle. It is not a tight suction like you have in the intralace. So there could be a loss of contact, and it depends on what level you are having a suction loss. If you have started the procedure and the suction loss is less than before 10% of the first section has been happened, the machine will automatically go and restart. If the lenticule cut is happening and you have crossed the 10% limit, then there is no other way but to convert it to a femtosecond LASIK flap rather than trying to do a smile at that particular time. If there is a suction loss during lenticule side cut, then you have to repeat from the side cut and decrease the diameter by 0.2 to 0.4. And if it is during the cap cut which is there, you repeat for the cap cut using the iris recognition register for the infrared for recentration that is there. And if it is during the side cut, you repeat only the cap side cut by decreasing the diameter. So let me just show you various places where the suction loss can happen. You can see in this particular case, this is happening you lost suction. So therefore it is at a point where we can only make it into a flap. So this suction was lost when the cut was more than 10%, and therefore we had to make it into a flap. Now, if there is a suction loss which has happened after stage 2, that means it is at the third stage where you are cutting the anterior part of the, that means that the cap cut is happening. You can see this is the posterior lenticule cut that has happened, which is fine. 360-degree side cut has happened. And now you can see that there is a fluid coming here at this particular point, and there is going to be a suction loss. You can actually stop because there is no way you can retrieve. So you stop here and you will go and redock with the same coil. The machine will guide you. You do the infrared for seeing whether it is centered. There in this particular case, now you are starting from point number 3, that is the plane above the lenticule. You can see there is a decentration from the first cut, but it will not matter. And this is the side cut that has happened. And you can go ahead as if nothing has happened, because the femto will go into the same plane as was as it had when you started. So I'll just go forward. You can see we go into the 2 planes, and you can easily remove the lenticule without any problem. Now, if you have dissection difficulties, which sometimes happen even to the best of us, but in the learning phase, it is there, that you can see in this particular case. Just see this. There is the edge lift that has happened. The surgeon is pretty sure that he is in the proper plane that is there, and you can see that actually it is the posterior plane that has been entered, and the lenticule will stick on top. So once you are trying to now go into the posterior phase, you are not being able to get. So you are trying to fish it out with the forceps. So you have to therefore go back again and identify the plane. So you can see here we have identified the plane, and now we are trying to do like a reverse capsulorhexis, and we go in once the plane has been created and separate it out. So the key is to be very careful as regards the identification of the planes. And in this particular case, it's the reverse, where we have done the anterior separation later as compared to the posterior. And again, you can see that we are able to take out the lenticule as it comes out here. Now, the other thing is that in case there are cold spots which are there, that is going to be a problem. So you have to be careful. Rarely you can have problems. You can see that part of the lenticule has come, and there can be lenticule that can be stuck. You can use triamcinolone tricot to stain it, or you can use fluid, or you can use the microscope. So you see here that there is a part of the lenticule which has been torn. And therefore, even the fluid is giving you the lenticule separation, and OCT will also guide you if you want, but you have to take out the entire lenticule, place the edges of the 2 parts that are there, and get it out. This is a straight forceps. I don't use a straight forceps. And if you have a straight forceps or any other forceps and you lift your hand up, under those circumstances, you can have a tear. So it really will not matter as regards the final outcome, but you have to maybe put a contact lens and be very careful that side cut extensions do not happen, because it can cause some amount of irregular astigmatism, nothing else. You don't get epithelial ingrowths, but it is very rare that if you push the epithelium in, you can get an epithelial ingrowth in these cases. We were among the first people to report a case of iatrogenic ectasia in these cases. So the parameters that you follow in a smile have to be identical as you have to follow in a flap LASIK, as regards the residual bed thickness, the corvis, etc., and the pentacam topography that you have to do. And we have reported this iatrogenic ectasia, which has happened in one eye of an individual, while the pentacam was all right, and the follow-up of the second eye is still going fine. This has been reported out of Eye Foundation by Gitansha and Shreyas and Dr. Ramamurthy. Sterile corneal infiltrate, as you can see, which responded, which happened. The reasons are obviously not known as to why, but it responded to a course of steroids. So this is another problem that can happen. So finally, I'll just wish to say that there are challenges that happen with smile, but overall, if you, after the learning curve of about 25, 50, 60 eyes, that's what we feel is there. These challenges are rare, but they are manageable without significant or without any visual loss that has happened. and there is no loss of best corrected vision. However, what is important is that you need to have somebody guide you right in the beginning, and you should have appropriate knowledge for management. I think there is some amount of skill set that is required in doing the procedure of SMILE, and you need some amount of surgical dexterity that is required to give you good outcomes for the patients. So that is what I wish to say, that the limitations of SMILE, as I told you, hyperopia, no cyclotorsion compensation. You have to do manual marking, as was described by Shri Ganesh, but I think soon we will have cyclotorsion compensation, and new machines that are coming are having cyclotorsion compensation. And there is no SMILE on top of SMILE for enhancement that is available just now. So these are few of the limitations, but since it is a new procedure, only about a decade old, these things are going to be overcome very soon, and this is it is going to. So the evolution of refractive surgery is taking us closer to preservation of corneal biomechanics. Dry eye is much less, and SMILE is one of the latest techniques to achieve this, where there is a fundamental shift from being flapless. So it is flapless and bladeless, as one says, and SMILE is, at least in our practice, it is the preferred technique, and more than 90% of our patients are going in for SMILE. And it gives excellent results and happier patients as regards patient satisfaction and outcomes. Thank you very much for your kind attention.
Thank you, Dr. Mahipal, for that wonderful overview of the SMILE surgery. I would request Dr. D. Ramamurthy and Dr. Rupal Shah for their quick comments.
I think Dr. Mahipal.
Dr. Rupal Shah, ma'am?
Yeah, I thought Dr. Ramamurthy was speaking. So let him finish talking.
Go ahead, please go ahead.
Okay. So it was a wonderful presentation, Dr. Mahipal, and it was quite complete, and I tend to agree with everything that you have said. What I also would like to add is that we are now studying the 10-year follow-up results of SMILE, and they are really very promising. They are showing the same safety, stability, predictability as we had seen on the first year of the SMILE technique. And so it is something that's going to stay. It's not a procedure which is going away, and probably will become a procedure of choice in the near future. So I would in fact encourage everyone to at least learn, see, and conclude for their own self how it is and how it is getting practiced, and definitely include that as one of the armamentarium in their refractive practice. It's a very useful tool, and I would really urge everyone to make use of it. Dr. Ramamurthy.
I think in the short time available, Dr. Mahipal covered almost everything that needs to be said about SMILE. Just a couple of points. Whenever you have a suction loss, even in the most experienced hand, there's a little bit of unhappiness, and you're not unsure of what needs to be done. Please be rest assured the machine actually guides you exactly what needs to be done, and you follow the monitor, and most often you're home safe. One thing I don't do is, even if I lose suctioning during the lenticule cut, there's a suggestion that we reduce the overall diameter a little bit. I don't do that. Go ahead and use the same PI, and most importantly, there's some amount of OBL that's there. So go with the infrared monitor. That gives you a much better visualization than looking through the operating microscope. And as far as the occasional cases which has residual power, or there is a regression, of course you have various options, and circle is a great option. We have tried it in a couple of cases, but that comes at a cost. In our experience, we have found that PRK over SMILE also functions equally well. So you could always try that out when you're faced with that situation. But otherwise, I think even in our hands, it's an excellent, I think in the center where we have it, is our preferred modality. More than giving any great results, which is much better tthan femtosecond LASIK, is the fact that the patients who undergo this immediately after surgery and the first post-operative day are much more comfortable compared to a patient who has undergone a flawless femtosecond laser. I think otherwise the ultimate results are not only in our experience, but even the studies have shown that are quite comparable.
Thank you so much, sir. Any comments from any of the esteemed panelists or even speakers?
Can I just ask a question to Dr. Ramamurthy? Can I ask a question to Dr. Ramamurthy?
Yeah, please, madam.
It's an excellent presentation by Mahipal. I just want to know, has there been any situation where you could not complete the smile on that day and you had to take it up at a later date? Or will you continue to do the smile if you're going to do it at a much later date, or would you do a PRK?
I think, right in the initial days, we had one or two situations. It's most important to review your laser passage. Supposing the laser has been complete and flawless and you did not have much of an OBL, even a week later, 10 days later, or gone back again because it was done by a novice surgeon and got the lenticule out. And all of us have shared videos where fragments of the lenticule have been left behind that has been taken out a few days later. And that's the reason I always make it a point to spread the lenticule and make sure it's complete, even though everything has gone up unevenly. And another important factor is, in case I'm in doubt, and if it's a small power and it seems to be a very difficult dissection, I think I've just done it a couple of times. I just go ahead and do a PRK. I feel that that's much safer than going around trying to dig for the lenticule, which is not the, which you find it extremely
on the
difficult.
same sitting or at a later date?
Once I did it on the same sitting, another case on a second sitting. But most often you are able to get the lenticule out in toto.
So, Dr. Sujata, I'll just wish to say that if there are uncut areas which are pretty large, sometimes that happen, like for example, the one that I showed us Celia, but sometimes if you dry, the cornea gets dried. That is the one of the major reasons that is there, that or there is something that happens on the optics or the undersurface of the cone, but whatever, that you are not having a pass that is happening. You can do a PRK, that's the OBL disappears in some time. That's not really a problem. So you can do a PRK, but what you can do is that you can convert it into a flap. There's absolutely no problem in, like in an intralaser, you could rerun this thing. The only thing is that maybe you could immediately convert it into flap and do a femtosecond laser. But if you want to do a smile on top of a smile with these problems, then you will have to wait.
Sir, just one question from my side, sir. Did you had any experience of having a lot of black spots in the interface? Then you really had a difficulty to dissect and just left the case there. Then next you postpone the case for PRK. Did you had any experience?
That is what I'm trying to say. These are the uncut areas, and why you have black spots is the biggest cause is the drying of the cornea. We often overlook that the cornea is dried at that particular time. If somebody is learning, you have put the speculum, you put a paracane and things like that, and the cornea dries up and you're trying, so you will not get the cut areas which are there. Unfortunately, you cannot do anything much at that particular time. If you're getting a lot of spots, I would say that you could by clinical experience, you know that whether these spots are going to make any difference or not. If there are huge, large uncut areas, then there is a problem. I still remember Sonu came for a live surgery in 1 hour in one of the conference in Center for Sight, and there was this thing, and he very deftly handled that. You take the duckbill separator, which has a semi-sharp edge, and you can do ahead and do a lamellar dissection like you do a dissection for doing a LK and things like that. So it depends on the surgical experience that is there, but and on the extent of these dark spots. These dark spots are nothing else but uncut area. So either there is something, there has to be either a dry spot or something that is blocking the laser from coming and hitting onto the cornea. So you have to use your clinical judgment at that particular time, and you may have to abort the procedure if you don't want to do, obviously you don't want to do harm to the patient. If there is a large amount of area which is uncut, then that's what I said, maybe use another cone and you can make it into a flap at that particular time, or PRK as Ram said. But doing a smile at the same moment, if you have a large uncut area, would be difficult.
Just a small tip I want to offer, in the sense that, just before, you want the cornea to be moist, but you want the conjunctival sac to be dry.
Yes.
Just before docking happens, we put a couple of drops of saline or BSS and use a swab stick at the fornices to dry it out. But the cornea remains moist right at the time of docking. And I find that, as Mahipal said, if you have dry spots, that's the reason you get those black spots, which are uncut areas. Once you do this, I think the chance of loss of suction is also less. At the same time, you have a moist cornea.
Just for the people, what Ram has said is that in case you have a lot of fluid around the suction and into the conjunctiva, the loss of suction is a much higher possibility there. So you don't have to, in the best of hands, I would say that the incidence of suction loss may be close to 0.5 to 1%. You still that those things are possibly not in your control. It has been reported between 1 to 2 to 3% on the suction loss. It could be there. But as Ram said, the machine guides you, and more than 95% or 99% of the cases, you can come out unscathed, even if you have a suction loss.
Thank
Can
you
I
so
just
much.
add one small point? It's also a good idea to put your speculum in only once you are ready to dock and you are quite close to the contact glass, so that the patient can look straight ahead, so your centration will be perfect. Also, your corneal environment will remain constant and not get dried at places, and differential dryness will not occur, and you can avoid these problems quite easily.
Thank you, madam.